patients have a multitude of signs and symptoms. And again, on an exam, when you're looking for it, to say, okay, I'm looking for these specific signs and symptoms, makes it a little bit easier. But in real life, patients don't come in and say, I've got these things here, and what do you think is going on? They have this, and then you ask them, oh yeah, and then they go off on a tangent, and then so it takes a little bit more time to be able to figure out exactly what's going on with these patients. We got our TLOs and our ELOs. Let's do a little bit of a refresher. Arboretum.
Yes.
Okay, we've got a 49-year-old female comes in, abnormally bleeding for 8 months. Which one of these might be a structural cause? Yes, we have.
Well, it's not A because we haven't talked about it.
We haven't talked about it. Although, did we?
It is structural, so I don't know. B?
Me? But why do I feel like you're not confident in that answer? Do you remember something called palm and coin?
Oh. AC was not that day. AC was not.
I like it. Okay, anyway, so when you study for this test, not the test you're studying for now, remember palm and coin. So palm is your structural causes, 25%, and we have polyps, and we have adenomyosis, and we have leiomyomas, which are also called uterine fibroids, and then we have malignant hyperplasia. And then we have coin with a little quarter, and that's all your non-structural causes, 75% can go. 75% of the time, oh, and you did it. 75% of the time, non-structural, like coagulopathy, ovulation, but part of that point is endometrial. We have endometrial hyperplasia, but you also could have endometriosis that can cause that. All right, but for this one, leiomyoma would be a structural cause. All right, so now, let's go with DAS. Okay, sir, 47-year-old female presents with chronic recurrent hypermenstrual bleeding for 6 months. She's coming in today because these symptoms are now affecting her ability to perform routine activities. Treatment. What do we want to recommend as the most effective? Not that you can't give lots of things, but what is the most effective? No, don't be honest. We're not handling any more honesty today. Delta, D would be preferred. There you go. Okay, the IUD is preferred because it causes endometrial atrophy and then ultimately reduces the amount of bleeding these patients have. Conjugated estrogen, that's going to be when acute bleeding. We can do that early, but these are patients that are bleeding significantly in the acute phase. Hydroxyprogesterone acid, you could do that. Progesterone contraceptives, you could do those. TXA is an additive, but the most effective, according to the literature is going to be the hormonal estrogen. All right, so that brings us to endometriosis. Again, affects about 10% of the population, almost 2 million people of reproductive age, typically between the ages of 25 to 35 is what we're going to see. Now, when we think about endometriosis, we know that the endometrial lining of the uterus must be involved, right? And we know that that's where the majority of our endometrial cells are at. The problem is for some reason, in some people, those endometrial cells then propagate and they go outside of the uterus, but they still proliferate outside of the uterus. So they can actually go and encase the ovary, they can encase the uterus itself, okay? They can go all the way up through any part of the peritoneal, even up to the pleural space. And there's even literature out there that shows endometrial cells in the brain. So that's crazy. So it can go really anywhere, but the majority of times we're going to see this, and the signs and symptoms patients will see, is typically within the pelvic cavities of the peritoneal cavity. Many patients don't even know they have endometriosis. endometriosis. At least not initially, and I say initially, it might be for several years before they really have signs and symptoms enough that they're putting together, like, this is starting to bother me, and this is starting to affect my daily life. But what they may come in earlier with is infertility. I've been trying to have children for the last several years, I've been intercourse for time, not using contraceptive, but they're not able to get pregnant. So that may be their initial complaint is infertility. Otherwise, we think about this classic triad of symptoms. Patients often have dysmenorrhea. Now, this can be a cause of primary, but usually we think about this as a cause of secondary dysmenorrhea. Remember, secondary dysmenorrhea differs from primary dysmenorrhea in that these patients had a time period where they did not have painful menstrual cycles, and now they're having painful menstrual cycles. Dyspareunia, which is painful intercourse, okay, especially when you have those cells that are around the vaginal area in the pelvic cavity, it's going to start causing some scarring down, and that can cause painful intercourse. Dyschezia, painful bowel movements. Again, we have those endometrial cells that are caking around the rectum. So anytime they go to the bathroom, or even if they're not going to the bathroom, but around the time that their menstrual cycle starts, what do those endometrial cells do? What do they want to do? They want to start shedding, right? So they're going to enlarge a few days before that, and then they're going to want to shed, but they don't. So they swell, and they cause a lot of inflammation, a lot of pain, especially surrounding the menstrual cycle. But again, you can see these endometrial cells just about anywhere. Not that long ago, I was working in the ER, a person came in, they had chest pain, they had shortness of breath, they were tachycardic, and no hypoxia. I was like, oh, they probably have pulmonary embolism. And lo and behold, the CT of their chest, the CTA, and they had endometriosis of the pleural space. Okay, so now what was happening is when we go back and talk to her, yes, I've had some chest pain and shortness of breath, and when we really hone it down, it's typically starts a couple of days before the menstrual cycle, and it gets kind of worse in that initial portion of the menstrual cycle, and then it starts to get better as the menstrual cycle ends. So that was more commonly seen with something like endometriosis. You still have to do the imaging, you still have to evaluate because we weren't really sure what was going on, but ultimately she had endometrial cells all the way up in the pleural cavity. So we see this about 1,000 women, 1.6 in 1,000 women. Again, initially asymptomatic, but ultimately up to 70% or so are going to start having some degree of pelvic pain. Up to 50% of women that are infertile, it's due to endometriosis. So it is a big deal, and it's a big deal that it takes so long for us to identify this, again, 10 to 15 years. Adolescents had a laparoscopy done. So they went, they saw their primary care provider, they said, I'm having this pelvic pain, I'm having this abdominal pain. They go on several months, try this, and ultimately they were referred to OBGYN. They took them to surgery, they did a laparoscopy. 2/3 of those adolescents had endometriosis. 2/3 of those guys. That's young people having endometriosis. So again, it can be a cause of primary, we also think it causes secondary. So risk factors, if there's a family history, certainly. Nulliparity, so never been pregnant. Why do you think that might be a risk factor? Because what are endometrial cells sensitive to? What hormone? Estrogen. So nulliparity, you have more increase or persistent increase in estrogen, so or circulating estrogen. If you've never had a baby, then you tend to have those higher levels of estrogen. Okay, or prolonged exposure to endogenous estrogen. So someone's had an early menstrual cycle, early, late menopause, they have a longer exposure to estrogen in their lifetime. We're not exactly sure why do some people get endometriosis and others do not. So the most common theory is the Sampson theory of retrograde menstruation. And what they're saying is, yes, when people have a menstrual cycle, when they have their bleeding phase, okay, we know that that's going to come out of the vagina. Okay, but the other thing that happens, they will get some retrograde out through the fallopian tubes and into the pelvic area, peritoneal area. Okay? But the problem is that the majority of women have retrograde menstruation. Okay? if they look at the studies, the majority of women have French administration. So why do some get endometriosis and others do not? Why don't all women have endometriosis? So even though that's the most common theory, it doesn't truly explain why some women have endometriosis and why some don't. There's something called the Müllerian dysplastic theory, and here they say that the cells, the Müllerian cells themselves, or the duct system, creates this, it may introduce endometrial tissue to other parts of the body. Yeah, maybe. Maybe somehow those endometrial cells get into the lymph nodes and they're spread via lymphatics. That's another theory. Maybe these actually start off as undifferentiated stem cells that we have all over the body, and that for some reason they turn into endometrial cells. Maybe that's why we have them in the brain. We really don't know. And if you don't understand why something happens or how something happens, it makes it a lot more difficult to treat that something because we don't understand the pathophysiology of it, right? Which is why oftentimes these patients take so long to come in with their signs and symptoms and so long to be treated. So we think about the signs and symptoms associated with endometriosis as the Ds. We have dysmenorrhea, and dysmenorrhea, again, if we think about this as more of a common cause of secondary dysmenorrhea, primary dysmenorrhea responds pretty well to anti-inflammatories and birth control pills, and although that is certainly a treatment for endometriosis, you may find that patients don't respond as well to the anti-inflammatories or birth control pills with secondary dysmenorrhea. Okay? Usually that painful period or that pain associated with their menstrual cycle is going to start a couple days before in that late luteal phase, and then it will improve as the menstrual cycle starts within the first couple of days. The other D we have on there is dyspareunia. So dyspareunia, depending on where the lesions are located, will also depend on the signs and symptoms that they have. So we have dysmenorrhea, we have dyspareunia, we have dyschezia, like we already talked about. We have infertility, okay, for another D, and then chronic pelvic pain. So those are our Ds. Chronic pelvic pain. And so that is a common sign and symptom is when these patients start to have that persistent pelvic pain, because even though their symptoms tend to be worse, at least, in the early onset, around the menstrual cycle, there is a time period where they just have symptoms the majority of the month, okay? And they can also have some intermenstrual or some intermenstrual spotting associated with this as well. Most of the time on pelvic exam, most of the time by manual exam, it's going to be normal. Now, sometimes we may feel an adnexal mass. Or if they're having pelvic pain, we may actually get an ultrasound to assess why you're having pelvic pain. And sometimes what we'll see on that ultrasound, or if we do feel a mass, sometimes it's related to these endometriomas. So endometriomas, let's say a person comes in, they've got the Ds, you're like, oh, maybe, or they've got pelvic pain, I gotta do this ultrasound, but we don't really see anything on exam, nothing else on history, like you can't really put all the HPI together to say, I think there's endometriosis. But you get that ultrasound, and the radiologist says, the patient, this is consistent with an endometrioma. They have endometriosis. They will not have endometriomas without endometriosis. So endometriosis or endometriomas are more of a sign that they have probably pretty moderate disease of endometriosis, right? So then that is now you're starting to work backwards. Okay, well now I have kind of the diagnosis because I have this endometrioma. Now what am I supposed to do? Now sometimes on exam, okay, if we do an exam, sometimes the uterus will kind of be fixed if you have those endometrial cells that are scarring the uterus down, it'll be fixed. So when you go to do your cervical motion tenderness, people are like, oh my gosh, that really hurts, but you don't see any discharge, you don't have any risk for PID, and you're not really thinking it's PID, but pain with cervical motion or cervical motion may indicate endometriosis in the person. Sometimes if you do a rectal vaginal exam, you'll actually find, feels like little BBs, okay, but you can feel the septal nodules. You can feel some ligaments and some septal nodules back there. Kind of a weird feeling. I've never felt that, but that's what the literature says that you can feel. Sometimes on the bimanual exam, on the adnexal exam, so the uterine ligaments kind of go along from the uterus over towards the ovary, and sometimes on those ligaments you'll feel some nodularity as well. But I wouldn't count on it. I would say that the majority of time on your bimanual exam, the majority of time on your physical exam, nothing's going to lead you to believe that this patient has endometriosis. Most of it's going to be from sitting down and getting a really good history on these patients. So these chocolate cysts look like that, what they call them chocolate cysts, endometriomas, and what they have in there is, what is all that dark stuff? Dried blood. Dried blood, so we call it chocolate cysts. Okay. Our history and physical exam, mainly our history is going to be the biggest thing that's going to help us out with these. Labs. Certainly you can do labs, especially in a patient that maybe has a higher risk for STIs, okay, but unfortunately there's no lab that's specifically going to lead you to believe or not that this is endometriosis. Okay, so you should do a CBC if you're going to do labs, do a urine test, do an HCG, okay, and then STIs, so vaginal swabs for gonorrhea, chlamydia, bacterial vaginosis, trichomonas, candidiasis. Those will all be appropriate because this patient, again, is probably coming to see you with either dysmenorrhea or pelvic pain. Well, that's hard to work up for pelvic pain. And then ultrasound, especially if they're having adnexal pain, we want to get that ultrasound. If they have persistent pelvic pain. And it also helps us determine, is there something else that's causing this pelvic pain? Do they have an ovarian cyst? Do they have something else that's growing? What else is causing their pelvic pain? It's not specific though for endometriosis. So if we do not see an endometrioma, it does not mean this patient doesn't have an endometriosis, right? They can still have endometriosis, but we're not going to see just endometriosis on the ultrasound. We can see endometriomas that tell us they have endometriosis. If they don't have endometriomas, it does not say they don't have endometriosis. Because really, the best way and the only way to diagnose endometriosis is by seeing the lesions. By seeing the lesions, and that's usually done via laparoscopy. So again, these patients are having chronic symptoms. They've had 3 to 6 months of this pelvic pain. May probably much longer than that of dysmenorrhea, dyschezia, dyspareunia. Okay. At this point, we've tried anti-inflammatories maybe because we're trying to treat their dysmenorrhea. Nothing's getting better, so we send them to our consultants, so OGYN. They do a laparoscopy and they visually will see the endometrial lesions. And what they're looking for is these dark spots. So this is actually, this picture here is actually a pelvic exam. So it's a speculum exam. And if you see this on speculum, so this is the cervix here, cervical os is right here. We've got these dark areas here, and then posterior, in the posterior fornix, okay, we have these dark areas here. That's endometriosis. Probably pretty significant form, but that we're seeing for us to be able to actually see exactly what we're looking at. And then when we look over here, this is a little bit harder to see, but these are the uterosacral ligaments, and there's little nodules on these ligaments. So you can imagine, again, on bimanual exam, that it would be pretty hard to be able to feel these, but that's what the literature talks about, is these uterosacral ligament nodules. We also see some darkening here and some darkening here. And then look on this ovary. This is your ovary, nice and pretty, but what's not so pretty is we have these dark lesions on the ovary. Okay, so they can completely encase the ovary. Well, guess what? If the ovary has a bunch of endometrial lesions, it's not going to respond as well to LH and FSH. We're not going to have that ovulation that we would expect these patients to normally have, because now the ovary is not functioning appropriately because the hormones are being changed by the endometriosis. So how do we treat these patients? We have medical options, we have surgical options, but the majority of times it's a combination of medical and surgical therapy. So for medical treatment, we can certainly use those anti-inflammatories. Okay? We can use progestin only, so something like levonorgestrel IV or oral progestins. The thing to remember about oral progestins is they're very sensitive. So a person takes a progestin pill at 3 o'clock on a Friday. Guess what? On 3 o'clock on a Saturday, they must take it, and 3 o'clock on Sunday, 3 o'clock on Monday. So pretty much they have to be within 2 hours every single day. Well, that's hard for people, so sometimes that oral progestins are not a great medication for the majority of women. Okay, we can do combined oral contraceptives. And again, I want you to think about how these medications work. So how does levonorgestrel IUD work? The ultimate thing is it thins the lining of the uterus, okay? So it causes atrophy of the lining of the uterus, so we don't have such a proliferation of endometrial cells. How would combined oral contraceptives work? They have estrogen and progesterone. We know that this is an estrogen problem. Do we want to throw more estrogen at it? Well, what do they, if we put them on combined oral contraceptive, what does it do to that estrogen level though? Keeps it consistent. So we don't have these spikes in estrogen, which is usually the time period in which these patients have worsening of their symptoms. Danazol, we talked about Danazol previously, and that's okay for these patients with endometriosis, but there's a tremendous amount of side effects. This is an androgen analog, so now we got acne and we got hair growing everywhere, right? And then the GnRH agonist, we typically would consider that second line. Oftentimes they use GnRH agonists either just before they're planning on doing the laparoscopy to see if they have improvement, or after they do the laparoscopy to help keep the endometrial cells and endometriosis at a minimum if possible. Okay, so anti-inflammatories, it doesn't matter which anti-inflammatory. Okay, so if someone's on ibuprofen, just make sure they're on the correct dose, 400 to 600 milligrams, okay, 3 to 4 times a day. You can do naproxen, but it doesn't do any good if they're on ibuprofen. You say, well, you're on ibuprofen now, I'm going to change you to naproxen. Changing the anti-inflammatory does not help. Okay, you can just choose one and go with it. If it doesn't help, changing is not going to change the outcome. And then for the combined oral contraceptives, you could use continuous or we could use cyclic. So continuous, remember, something like a season-E, where they only have a menstrual cycle every 90 days, or they could do the 365, they don't have a menstrual cycle at all. You could do that. You could do cyclic, where they have a menstrual cycle every month. So you can do either one of those, but the continuous dose does appear to be more beneficial for patients in reducing their pain. Okay? Because again, we're not having the spikes of estrogen except for once every 90 days. If we're using the extended cycle, then they have it. They don't have it all, right? So what we want to do though, we don't want to give them high levels of estrogen. So typically, if we can, we start with that 20 micrograms of estrogen. If we have to increase that a little bit, we can do 20, we can do 25. But really, we want to stay around that 20 to 25. We want to have them on the lowest dose of estrogen possible, so we don't increase the amount of endometriosis that they have. For progestin therapy, we have lots of different progestins that we can use, but levonorgestrel IUD is going to be one that's tolerated the best and probably the most effective for the majority of these patients. GnRH agonists, we know that they are pretty good medications, but the primary side effect associated with them is pushing these patients into a pseudo-menopause. Okay? Because it's a GnRH agonist, so the GnRH is going to affect LH and FSH release, it's going to affect estrogen release as well. And so estrogen levels are going to be low in these patients, which is good, which is what we want, but when they have low estrogen levels, then it puts them into the pseudo-menopause. So the hot flashes, night sweats, all of that. So we don't typically use that as initial therapy. We can use that as a secondary therapy or again after surgery. And then what we're looking for patients who have GnRH, what we have to think about is if these medications work well for this patient, so let's say we put them on Leuprolide and we're like, oh man, this works great. How can we maybe reduce the potential of them having those menopausal side effects? We can do something called add-back therapy. So the literature talks about add-back therapy, that we should begin it. So at the beginning, you don't have to start it, but by 6 months of GnRH therapy, we should have these patients on add-back therapy. Okay? And add-back therapy, we're giving them an estrogen, usually a low-dose combined oral contraceptive. We're giving them back to help reduce the side effects or reduce the chance of them developing menopausal side effects. And then the literature also talks about how long should we use these GnRH agonists. So I suppose some people would say we could use them forever. Well, the literature says probably we shouldn't. We probably shouldn't. And really, we probably should cap this at 12 months. Now, that is not the same thing for everybody all the time. But in general, when we're prescribing these, we should cap it at 12 months. So a person comes in to see you, and they're like, oh man, I got put on this GnRH agonist, I'm like 5 months in, I feel great. The first thing should be, that's great. But also, let's talk about add-back therapy. Let's talk about what we're gonna do. We're gonna add back a medication to help with that, because even though you're not having side effects now, we're gonna probably, pretty soon, you're gonna start having these side effects, and we wanna give you something to avoid that, prevent that from happening. Okay, now they're 11 months in, and I feel great. Okay, well, that's great, but we need to stop this in about a month. Because if they need to continually be on GnRH agonist, we need to provide some more definitive. That should not be your definitive treatment for these patients. Maybe they need to have surgery, and when they do surgery, surgery is both diagnostic, so it's going to see those lesions, but it's also therapeutic. They can go in there and they can lyse those endometrial lesions, okay, and help slow the progression of disease, of endometriosis as it's returning. It's not going to get rid of it forever, but that'll slow the progression. So add back therapy, again, we can do something like a norethindrone. We can do a conjugated estrogen with a progesterone. We could just do a low dose combined oral contraceptive, right? That works just fine. We could do transdermal, okay? But remember, if you're giving patients estrogen, you must give them some sort of progesterone along with it. Okay? You must, because these patients have, most likely, if they have a uterus, you have to do that. Now, there are some people that have had a hysterectomy and they still have endometriosis. If they've had a hysterectomy, you don't need to. But most of these patients we're talking about have not had a hysterectomy. You cannot give them estrogen alone, because that increases their risk of cancer, especially something like endometrial cancer. So those are options for add-back therapy that we can give these patients at a minimum at 6 months. Okay, start from the very beginning. If you want to put them on add-back therapy, you can do that. And then in total, GnRH therapy should not be more than a year. For surgical treatment, so if this patient desires future fertility, so they're coming in and got this pelvic pain, infertility, then we can do this laparoscopy. Or we can't, but the OB-GYN surgeons can do that. And again, it's diagnostic and therapeutic. They go in and lyse those lesions. Okay? If there's endometriomas there, the recommendation is if it's endometrioma greater than 3 millimeters or 3 centimeters, then those should be removed. The smaller endometriomas, they can stay in place. Now, if they're doing a laparoscopy, a lot of times we'll do them anyway. But let's say we did an ultrasound and all that, on that ultrasound it says you have to have a 2 centimeter endometrioma. They don't need emergency surgery. Okay? They don't need emergency. You can watch those patients for a while. You can repeat that ultrasound in 6 to 8 weeks. If it's still not growing, you can repeat it again, because we don't want patients to have surgery unless they need to have surgery. But if the endometrioma is greater than 3 centimeters, then the recommendation is they take those off, because it makes the ovary lopsided a little bit, and the amount of pain that these patients have with these large endometrioma sensitive is significant. Now, if the patient says, I'm done with childbearing, I don't want any more children, then they can be offered a total hysterectomy with bilateral supplementary hysterectomy. Okay? So what they're going to do is they go in there, do a hysterectomy, remove the fallopian tubes and the ovaries, because we want to reduce the chance of endometrial cells growing even more. Okay? And then they're going to lyse those lesions that are in there. Unfortunately, the majority of these patients, this is not a once and done. They often go back and have repeated laparoscopies, sometimes every year, sometimes every 5 years, sometimes every 10 years. So it depends on the patient. But usually, once you have endometriosis, it's kind of stays with you for a very, very, very long time, not necessarily for a life, but a very long time. And these patients often have multiple laparoscopies to help treat these lesions. Ideally, the goal of surgical treatment is to help remove the endometriosis is there, not really prevent progression, but slow the progression of disease if we can treat those lesions that are there. We want to relieve the pain, improve their chance of fertility as well if we're able to treat those lesions, okay? And then if we can, reduce the chance of reoccurrence with surgery. So if we look at this flowchart from our book, Williams Gynecology, say if the patient, we have signs and symptoms suspecting endometriosis, so they have the D's, right? dysmenorrhea, dyspareunia, pelvic pain, maybe infertility as well. And their primary concern is infertility, well, let's treat their primary concern. Okay? That may be, probably will be with laparoscopy. We can treat those lesions, but we can also do medications, clomiphene citrate, CC, intrauterine insemination, they can do that as well. So the primary concerns that are coming to see for infertility, we've got to make sure that they have endometriosis, and do laparoscopy, and then in addition to that, they typically will give these patients medications. If their primary treatment or concern is pain, how much pain are they in? If I don't know, I just have this pain every now and then, okay, or they're perimenopausal, or they're close to menopause, we may not have to do anything. Let me know if the amount of pain that you're having increases, okay, or do you want me to give you something now? I can certainly give you something now, because some patients will be like, I don't really want anything, I just want to figure out what's going on, right? So we can do what we call expectant management for those patients. As they go closer and closer and closer to menopause, their symptoms should improve because we don't have as much circulating estrogen. Okay? If they have mild pain, anti-inflammatories, combined oral contraceptives, progestins are fine. GnRH, again, not as a primary, but a secondary line of treatment. If their pain persists, we need to make sure what is going on. Let's send them for a laparoscopy. Maybe they need some of these lesions treated to help improve their pain. Okay? And then post-operative, once they've had this laparoscopy, some of those lesions have been treating, then we go back. When they come out of that surgery, they typically are almost immediately put on some sort of medication to help slow the progression of these lesions as they come back. Okay? So we've got our adult for GnRH agonist plus that minus that add-back therapy. Also, you can think about diazole, combined oral contraceptives, or progesterone. All right, so we've got a 25-year-old female that's coming in. She's got severe pelvic pain, especially during her menstrual cycle. Sometimes the pain is so bad she can't go to work. She's got these heavy periods. She's got regular periods lasting 4 to 5 days, not really heavy, sexually active with one partner. And then she's had pain with intercourse for the last 6 months. So she has pain from menstrual cycles, pain with intercourse, pain with bowel movements, with defecation. Okay, well, we got 3. Okay, and she says, I'd like to have a baby, but not for a couple of years. Okay? On exam, she has cervical motion tenderness, but no discharge, no real STI concern. Ultrasound was done, and it's normal. Okay. We have to think about our differentials with this. Our differentials start like this, and we start taking things off. But you can see, if you have a patient that comes in, especially someone's like Chad and Kathy, right? You, in between they're talking to you, you're trying to pick out these specific words. You're trying to, okay, what do they say? What they say? Now, what are your main complaints? Oh, so here we've got pain with intercourse. We've got pain with bowel movements. We've got pain with menstrual cycle. We've got to pick those words out from these patients that want to talk to you about. And then you come with your differential diagnosis. So we talk about some stuff that we've already talked about. Adenomyosis could be in there. That's a cause of pain and can also cause abdominal bleeding, right? PID, we can think about that as a cause of pain, but usually in cervical motion tenderness, usually it'll have some discharge or STI concern. Leiomyoma can cause that. Some of the stuff that we've already talked about. So all of those, we think about those. We look and say, well, she's got 3 Ds. Those are the most common things that we're going to see. Maybe, in fact, this is endometriosis, right? So endometrial hyperplasia, are we typically going to see that on physical exam? That's going to be an ultrasound. We can see thickening of the endometrial lining. Uterine fibroids, sometimes you might feel something in physical exam. Again, ultrasound, same thing with adenomyosis. The only thing not ultrasound, pelvic inflammatory disease, should be a clinical diagnosis. So what is the best treatment option for this patient? She's pretty young, right? We probably don't want to do a hysterectomy. Physical therapy, there is such thing as vaginal physical therapy, but not for endometriosis, so probably not going to help her. Do we do medical management for this patient, or do we just say, we're going to monitor you, come back in another 6 months? Yeah, probably medical management, right? Because she's already been dealing with this for a period of time, right? So probably medical management. So we give anti-inflammatories, we give combined oral contraceptives, We could provide progestin contraceptives as well. Okay, so those are things that we can talk to our patient about and see what they think would be best for them. And we can do a combination. Can you do anti-inflammatories and put them on combined with contraceptives? Certainly can. Right? So the patient comes back, you decide to put on anti-inflammatories, you give her combined oral contraceptives, she comes back in 3 months and she says, hey, look, I'm not any better. I'm not any better. I don't feel like this is helping me at all. The next step is, in your mind, you're like, well, darn, I thought maybe she had endometriosis. Why isn't she better? She should be getting better. Maybe not. Maybe not. You know, she's been dealing with this again for quite some time. So we got to ask ourselves, let's go back through our differentials and let's make sure we didn't miss anything. Does she need STI testing? Is there anything else that you can think of in your differential that maybe we missed? Okay, and if so, let's address that. If not, this may be the time. Now this lady is multiple months into this. Okay? So now maybe we should refer this patient and say, look, concerned for endometriosis, tried a 3-month course of anti-inflammatories and combined with contraceptives, not any better, please evaluate further. Nothing wrong with that. Could you get an ultrasound on this patient? Should you get an ultrasound on this patient? Probably should. Probably before you refer them, I would get an ultrasound, right? And that's going to help you with your differential. Well, it's not a lot of adenomyosis, no indication there, leiomyoma, no indication. But we want to figure out, does she have endometriosis? So ultimately, you say, I'm going to send this patient to the consultant. Ultrasound looked fine, physical exam was okay, did some basic labs, all okay. She went to the operating room, they did a laparoscopy, and they said, oh, she's got endometriosis. So yay for you. She does not want to get pregnant. So after they did the laparoscopy, they lysed some of those lesions. They put her on GnRH agonist. Right? On a GnRH agonist, what are the side effects? Your hot flashes, night sweats, weight gain, all those things, right? So pseudomenopause. And if we're going to put the patient on a GnRH agonist, what is the time frame in which we should say enough is enough? 12 months. 12 months. Okay. So she comes in after 6 months and she says, I feel great. I'm super happy. I'd like to continue my GnRH. So you say, okay, that's fine, but I'm going to do add back therapy. Okay? And then you talk about the options for add back therapy. You add back this therapy and then say, oh, by the way, we can do this for another 6 months, and then we have to look at an additional different treatment. So now you have a 48-year-old female that comes in. She's had a 1-year history of pelvic pain. She was diagnosed with endometriosis at 25. She ultimately had 3 children after infertility treatment and a tubal ligation at 38. So she's done childbearing. She says, what do you recommend for me? Could we still offer her medical management? Sure, we can still offer medical management. Okay, but ultimately you can say, look, you know, you probably are a good candidate for a hysterectomy. You're probably a good candidate for a hysterectomy. We don't get to make that decision. We would just refer to OBGYN and they would talk to the patients about it. Yes, sir?
With her age and her getting closer to menopause, will that subside?
So we hope. We hope. We do think that the majority of women, that is the case, but not everybody. Not everybody. Now, for them to develop endometriosis after menopause, no. But they still can have lesions, menopause or endometriosis lesions that are proliferating. But as they go in closer and closer and closer to menopause, their symptoms should get better just by virtue of we don't have very much circulating estrogen. But unfortunately, that's not always the case. And so if we find ourselves in a situation where patients are like, I don't know, I don't feel like it's getting any better at all, then that's what we're talking about. So you can still offer meds, but also she would be a good candidate for surgical intervention if the OBGYN folks agree with that. All right. So remember, we're going to talk about the D's, dysmenorrhea, dyschezia, we've got infertility, and the chronic pelvic pain usually starts a couple of days before the menstrual cycle, and then gets better as the menstrual cycle. We want to make sure you have a high index of suspicion, because again, 10 to 15 years, women tend to go through this pain before it's finally diagnosed. That's a long time. So think about the key words and know that patients that are coming to see you, they don't know these keywords. They're not reading the textbook, so they're gonna use words that maybe make sense to them, but don't necessarily make sense to you. So you may have to ask them specific, all right, you have intercourse, do you ever have intercourse? Well, yeah, sometimes, okay, tell me about that. Tell me about that. So then you can really get a good idea of maybe it's just partner, maybe it's position, okay, or is it truly that they're having pain with intercourse? Okay? For these patients, we're not just gonna give them medication and see them back, I'll see you back in a year. Follow up with them routinely. Come back and see me in about 3 months. Let's see how you're doing. If they're getting some better, great. Come back and see me in another 3 months. Let's see. Because if we can avoid surgery, we'll do that. We can treat you with medication. Okay? But if not, refer them. What's the worst case that can happen? The OBGYN folks say, nope, they don't need a laparoscopy, follow up with your PCI. Okay, well, I'm already managing them anyway, so no big deal. Okay? And then certain surgical treatment often is going to improve symptoms, okay? But these patients, that doesn't mean they're not going to have reoccurrence of those endometrial lesions because they typically will over time. All right, that is it for today. Thank you.